everybody. Welcome back to This Emergency Life. This is Kevin. I want to welcome you back to your next shift. You're starting off your night shift today standing in front of Mr. Ramirez. He's 48 years old. He comes in complaining of chest pain. He's clutching the center of his chest. He says it's like the devil reached outside him and is giving him a tug. On your exam, he's pale. He's sweating. It's sweating right through his hospital gown that you have him in. On exam, his left radial pulse is weak, while his right radial is bounding. And the pain, he said it is so severe, he said it came on just like a car crash. Sudden, violent, and radiating to the middle of his back, like a shot was fired right through him. You've got choices here. This could be an MI. This could be a pulmonary embolus. If we're feeling particularly lucky tonight, it's going to be only reflux. But the reason we show up every shift is not because we expect to be lucky. We show up every night or every day to take care of our patients and to get it right for them. Key concept number one. When dealing with aortic dissection, we have to keep in mind this is not a polite disease. It is not going to knock first. It kicks the door in on you. When individuals have aortic pathology like aortic dissection, the intimal layer of the aorta will tear. The high blood pressure that it's experiencing to basically deliver oxygen-rich blood to the rest of our organs, it starts carving a false channel right through the wall of the aorta. If it tears into the pericardium, we get tamponade. If it tears into the chest cavity, massive hemothorax. If it cuts off the carotids, the coronary arteries, the renal arteries, the brain, heart, kidneys all suffer ischemic events in the form of infarcts, stroke. So what's the epidemiology of this pathology? 3.5 people per 100,000 per year. Rare? Yeah. Miss it? And the mortality climbs 1 to 2% every single hour. This is the disease that loves hypertensives. It loves people with connective tissue diseases like Marfan's. It loves the patient who recreationally or maybe not so recreationally utilizes cocaine, who when you ask about risk factors such as those will say, I don't do anything like that. It's just a little chest tightness. I have a cardiac history in my family. It loves exactly the patients you will want to believe are fine. So how do we know that this is a dissection? Right off the bat, you won't. Not at first. The important thing is that you have an open mind and you suspect this diagnosis in all of your chest pains. You grab blood pressures in both arms. You feel bilateral radial pulses. You listen for murmurs. You're going to look at their EKG, of course. For diagnostic purposes, the gold standard test for this diagnosis, for this pathology, is the CT angiogram. Of course, we're going to do labs. You're going to get your CBC, your chemistry. In this case, you definitely should be cross-matching for blood. You're going to plus or minus get a D-dimer, which in some people in the literature believe this to be a very excellent diagnostic test for showing pathology. Chest x-ray might show you a wide mediastinum. High index of suspicion is the most important aspect. Treatment-wise, you're going to want to give medications that slow down your heart rate and reduce your blood pressure. Beta blockers will always be your first line. So something like Esmol, short half-life that slows your heart rate. Second line is going to be your vasodilators, maybe something like your Cardine. Patients that are identified as a Stanford type A dissection versus a Stanford type B. Stanford A's involve your ascending aorta, so you're dissecting up really high in proximal, and type B is your descending aorta. So what does this mean for Mr. Ramirez? Mr. Ramirez has an aortic dissection. He is not going home tonight. His disposition includes either going to the ICU or the operating room. Nobody wakes up thinking today's the day that the aorta is going to rip open like a bad scene. And nobody becomes a nurse thinking that they're going to be the only thing standing between possibility and finality. But that's exactly what you are each and every day that you show up to work. You're a bridge between disaster and deliverance, between fear and fight, between losing everything and getting one more chance. You don't have to be perfect. You just have to be ready, prepared, ready to advocate. Because this life, this emergency life, it's messy, it's brutal, but it can be breathtaking. And it's worth every single second. That was aortic dissection. For any questions, comments, please reach out to me, and we will see you on your next shift. Take care.